maybe, okay, that's good, that's better. Good afternoon, thank you for coming to join us in person today. We have, this is a hybrid conference, a lot of people on Zoom, and we'll also have some interaction and question and answers from Zoom as well. So this is a conference on vaccine equity, so I'll just make just 3 or 4 minutes of some introductory remarks on what the conference is about, and then I'll turn it over to Michael and Saad for our first panel. What do we mean by vaccine equity? It's really about how do we now address the very unequal distribution of global coverage of COVID-19 vaccines, as well as very unequal access especially across continents. Yeah. So we'll start out with a panel with 2 of the world's leading experts on vaccine supply issues. So Michael Kremer from the University of Chicago has did a lot of the early work along with the US government on the incentives for vaccine development. And Saad, along with the WHO and other related organizations, have done a lot of the work on vaccine allocation and the global distribution of vaccines. Yeah. And so that's about supply. So we'll also follow this up with another panel this afternoon on vaccine demand, and in particular, not just questions of vaccine hesitancy, but also the internal distribution of vaccines within countries, within developing countries. Okay. Other than that, we'll have another panel on mask distribution, partly because from the distribution of masks, we have things to learn about effective ways of distributing vaccines, but also because masks represent an important complementary and supplementary strategies, especially in low and middle income countries where vaccine access is still not universal. And then finally, we'll have a panel focused on healthcare access and equity in Africa, right? And I just want to point out, this is the last thing I'll say, that we were eager to have and very proud to have a diversity of voices, right? So other than academics, researchers who you see on the stage right now, we have representation from government. So for example, Dr. Kangbai, who's here from the Sierra Leone Ministry of Health and Sanitation, and he's one of the main coordinators for Sierra Leone's vaccine program, right? We also have on the panel, the executive director of the world's largest NGO based out of Bangladesh, BRAC. Okay. We also have representatives from other agencies within government, such as the governor of Kaduna State in Nigeria. And also we have representation from, say, an assistant director general of the World Health Organization, right? So we are trying to take a broad and comprehensive view of this vaccine equity question, looking at supply and demand and getting and learning something from the many different sectors that are working on this question. So thank you for being here. And let me just make a few remarks of thanks, and then I'll hand it over and get the panel started. So first of all, for organizing the staff of YRISE, the Yale Research Initiative of Innovation and Scale. They've done a tremendous amount of work. Thank you to everybody at YRISE. And for funding, we are grateful to the Macmillan Center and the Kemp Fund in particular. Right? And then other funders who are involved in other ways. So you'll learn a lot about research today that has been supported by GiveWell.org, by the Bill and Melinda Gates Foundation, by the Douglas Marshall Family Foundation, the WISE Asset Management, and we have many research partners to thank as well, Innovations for Poverty Action, BRAC, the International Growth Center, Concern International in Sierra Leone, and others. Okay. So with that, let me turn it over to Neela to moderate the first panel. Thank you.
Hello, everyone. I'm Neela Saldana. I'm the Executive Director of YRISE, and it is my pleasure to introduce Dr. Saad Omer and Dr. Michael Kremer, who will be our first set of speakers. I don't think you could spend a better afternoon than starting off listening to them talk about vaccine equity. Dr. Saad Omer is the director, Yale Institute of Global Health. He's a professor of medicine, infectious diseases, and the associate dean at the Yale School of Medicine. He's also the Susan White Bliss Professor of Epidemiology of Microbial Diseases at the Yale School of Public Health. He's conducted studies in multiple countries, the United States, Guatemala, Kenya, Ethiopia, India, Pakistan, Bangladesh, South Africa, and Australia. And his research spans a wide variety, including the epidemiology of respiratory viruses, such as influenza, RSV, and now, of course, COVID-19, clinical trials to estimate the efficacy of several vaccines, trials to evaluate drug regimens to reduce mother-to-child transmission of HIV, and several studies to increase immunization coverage and acceptance. As you might expect, he has served on several advisory panels, including the US National Vaccine Advisory Committee and the WHO Expert Advisory Group for Healthcare Worker Vaccination. He has also served as an affiliate to the Office of Evaluation Sciences, formerly known as the White House Social and Behavioral Sciences team. So welcome, Dr. Omer. Our second speaker will be Dr. Michael Kremer. Dr. Michael Kremer directs the Development Innovation Lab at the University of Chicago, where he's a university professor. If Dr. Kremer looks familiar, it's because you might have seen him as the joint winner of the Prize in Economic Sciences in memory of Alfred Nobel, or inaccurately the Economics Nobel Prize in 2019 for an experimental approach to alleviating global poverty. Dr. Kremer's work focuses on innovation, including in education, health, water, finance, and agriculture. He's written multiple papers on incentives around innovation, including on patent buyouts, advanced market commitments, and approaches to funding social innovation. What you might also not know is that Dr. Kremer remains very active in translating the academic work into programs that have impacted literally millions of lives around the world. So his work on advanced market commitments for vaccines was instrumental in the development of a new pneumococcal vaccine, which tackles a leading cause of infant morbidity and mortality. And it's now been rolled out to 60 developing countries. And as part of the Accelerating Health Technologies Group, he conducted research on how to accelerate vaccination against COVID-19. And during his work on school-based deworming, he co-founded Deworm the World, which now brings, as part of Evidence Action, brings deworming to over 150 million children annually. His work on safe drinking water led to the Dispensers for Safe Water program, which reaches 4 million people via Evidence Action. And he's a co-founder of and a board member of Precision Agriculture for Development. He's also founded World Teach, which placed more than 7,500 volunteers as teachers in developing countries. He is a co-founder and serves as the scientific director of USAID's Development Innovation Ventures, which is an open tiered evidence-based fund that supports innovation for development. I'll stop there and sort of leave the time for the speakers to actually talk. We will have Dr. Omer and Dr. Kremer speak sequentially, one after the other, but then we will throw it open. We have quite some time set aside for questions. We'll take questions from the room, and then we will take questions from folks who are online. So please keep your questions coming because we will have time to take all those questions. Thank you, and I invite Dr. Omer to take the stage.
Thank you for the opportunity to share a few things around vaccine equity, and I'll use slides and sort of some explanations around the slides, but also we'll try to provide some off-script comments or insights around what has been happening in the area of vaccine equity. So we know that we live in a highly unequal world, and it hasn't become less unequal during the pandemic. And so this is the situation in terms of just one dose of vaccine around the world, and that this is the lowest of low bars out there for vaccination, because we know that even before the Omicron, we needed at least 2 doses to have a biological protection or meaningful biological protection against even severe outcomes, let alone infection. And now it's increasingly clear we need at least 3 doses, even of the most efficacious vaccines out there, which are the mRNA vaccines and to some extent the viral vector vaccines, and probably need more doses or a more creative booster strategy for inactivated vaccines that are used in big chunks of the world. And so, so this shows the distribution of the current vaccination rates by country. As usual, red is bad, green is good, without going into details. I would say the only nuance I would add is, in this case, red is really bad. And so going into a little bit more detail, the region that stands out, even within the countries, low and middle income countries, or countries that are developing economies, it's Africa, specifically sub-Saharan Africa. South Asia has done better. And so inequities are nuanced. And it's not just the income status of the country that matters, it's the geography and the specificity around where you're located, what your connections are, what is your industrial base, what is your technological base, and so on and so forth. All of that matters. It is not just the, as I alluded to, it's not just the number of vaccines that are out there, but the kind of vaccines that are out there. So from the very beginning, and we did not know when the vaccine development programs started and commenced in early 2020, which vaccines will be more efficacious. We had a hunch. If you had asked me to place bets, which I didn't, because I would have huge conflicts of interest, just to be clear, because I sort of serve in advisory roles that influence some of these decisions. So I'm just speaking figuratively. But if I were to sort of make bets, with friends in early 2020, I would have said that viral vector vaccines would be better than inactivated vaccines, from what we know, and mRNA vaccines are a wild card at that point. Since then, we know that mRNA vaccines are the most consistently effective vaccines that are available. Followed closely by, depending on the schedule, viral vector vaccines. And inactivated vaccines, wherever the evidence is there, are extremely useful vaccines. So for example, the biggest source of inactivated vaccines is China. And they did the right thing, and the Chinese government did the right thing to invest in these vaccines earlier on. But since then, so they've been incredibly useful, but are less effective. And the other disparity that I want to highlight, and the other inequity I want to highlight, is the inequity in data. So we have way more data about mRNA vaccines than we have about inactivated vaccines. And if I can show a few patterns in a situation of less vaccination, so Sinopharm, Sinovac are the major inactivated products, and look at where a lot of them are present. They're disproportionately present in sub-Saharan Africa as part of the market. And in fact, these numbers do not convey what proportion is inactivated versus viral vector. AstraZeneca vaccine, or the Oxford AstraZeneca vaccine, is by some measures the most widely used vaccine across countries. And so this inequity of data has meant that we haven't fully optimized schedules for, for example, inactivated vaccines, or even other vaccines in low-income populations, other vaccines in populations where we have, for other vaccines, find differences in effectiveness and efficacy. And so we are kind of at least partially flying blind in terms of sort of optimal vaccination strategy, in terms of number of doses, combinations, et cetera, especially in sub-Saharan Africa and to some extent in South Asia. We are not flying blind in terms of safety, fortunately. So the safety record has been pretty decent, and to our surprise, and that's one of the silver linings of this, safety data have been more robust than before. It's still not perfect, but the fact that we can learn across countries around safety data and there are different metrics around this has been encouraging. So around July, so there was sort of this initial target that COVAX, the entity that a lot of you may be familiar, which was a combination of this entity called CEPI, so Coalition of Epidemic Preparedness Innovation, I think that's what it stands for. Then Gavi, the Vaccine Alliance, and WHO, got together and said that we're going to have this mechanism where we're going to have this, we don't know which vaccines will work. We're going to invest in a bunch of development of a bunch of vaccines. Some countries will pay for these vaccines out of pocket. Some will, will facilitate that. So there are these sort of advanced market commitment, familiar word for this stage, countries, and we'll have this pool of buy-in, and we will then sort of give vaccines out to various countries based on their needs. I think it was a brilliant concept. And I think the start of implementation was very reasonable as well. A few things happened. First of all, the mRNA vaccine, especially the Pfizer vaccine, which was out of that system, turned out to be the one with the biggest manufacturing capacity, turned out to be earlier in terms of their clinical trials, because CEPI had zero investment from the US before the pandemic, which was responsible for doing these trials. The other thing that happened, and we don't talk enough about this, that it wasn't that we were, the US was lukewarm about the global system of vaccine access. There was an active antipathy of global collaboration around anything in this pandemic. If you remember, the US pulled out of WHO for some time in 2020. And even before that, so before you could advocate for putting in serious money into COVAX, you had a situation where folks, we couldn't even talk about that because they were pulling out, the US was pulling out of WHO. What it did was it started this cascade for every country looking out for itself, to an extent that in Canada, at some point, there were more vaccine orders than every person and moose combined in that country. And many times over. And so part of it was rational. You didn't know which vaccines worked, but part of it was this, sort of competition between countries where, in a non-collaborative situation, and they are sort of actual theorists of those kinds of phenomena, and without any, no pun intended, the games countries played were pretty significant in that kind of decision making. And that was pretty significant in undermining COVAX. So COVAX could not block that supply, could not provide that incentives earlier on. Then another thing happened in 2021, which was that COVAX understandably relied on the country which is the biggest manufacturer of vaccines for global supply, which is India. And Serum Institute of India, by volume, is the biggest player out there, made some sort of, at that time, rational bets or reasonable bets. But India opened up a little too early with 2% vaccine coverage. So Prime Minister Modi's World Economic Forum speech happened, I think, in early January with 2% coverage. And so India being the world's pharmacy speech, yes, you have to be, it's very reasonable to have that confidence, but you don't have that confidence with 2% coverage. And so India opened up too quickly and too aggressively, major elections, major religious festivals. And then at that time, the government de facto blocked major supply, which was going to sub-Saharan Africa through COVAX. So there was breakdown of trust. This happened before the India surge. But it then became very reasonable with the Delta outbreak in India. And so hence, this is reflected in the doses that were projected and delivered through the global system, which is mainly COVAX. And you had a situation where even through 2021, there was very little supply in the system. Because then at the later stage, it was very reasonable to India to block that supply. So some Chinese products came in and so on and so forth. In July 2021, there was this exercise at WHO that said, initially WHO said 20% of all population would be there because the groups were not defined. Then they set a target of approximately 5 billion doses or sort of the other ways of looking at it, actually the actual target was 70% of the world's population by June, July 2022. And, if any of you thinks that we are going to get there, I wish there is some way for me to get your optimism, because I would be mentally a lot more healthy if I had that somewhat irrational optimism, because we're not going to be there. So what happened in 2021 was, there was, especially right after the India Delta surge, there was a lot of domestic pressure and some was intentional advocacy targeting the public and the stakeholders in high-income countries, saying that we need, TRIPS waiver, which I'm not going to sort of go into the details of. So sort of basically, or a more comprehensive approach was technology transfer, sort of more end-to-end technology transfer to low-income countries, and direct donations. There was more movement on the announcements of direct donations. So there's, unfortunately, press releases do not produce antibodies and T cells. And an announcement on the eve of a G7 summit is 0% effective if it doesn't deliver doses. So there were major announcements, honest announcements in the sense with the projections of 2022, bulk of the delivery in 2022, but very limited, at least until late 2021, actual delivery. And there was a lot of sort of double count. Every time there was a ramping up of pressure at the eve of every major summit, you would have announcement either not for new doses, sometimes very rarely new doses, but also supply essentially from that committed dose, like 50 million, et cetera, which is a drop in the bucket in terms of what is needed. And so we were in a situation in country after country, and there is a separate demand session, but there is that added to the complexity in various countries. In country after country, I heard that we do not want to invest in demand side interventions, in communications interventions, and interventions to address misinformation, because we don't want our demand to outstrip our supply. That left that room for a lot of bad stuff to take hold, number one. Number two, you had a situation where countries had genuine uncertainty about what is coming their way. So they could not build their cold chains customized to the kind of product. Do they need a -20 cold chain or -70 cold chain, or a mix of those, or refrigeration? And they could not throw money at the problem and let the workforce be trained for. Remember, this is, either you take away the immunization workforce from your childhood immunization workforce, or you stand up new workforce, but they cannot let it sit idle for a year for your adult immunization. And so these problems became, and they actually spent a lot. So several countries actually spent a lot of money, which is not there anymore to spend now that there are doses. And so these are nuanced things that happen, and these are highly unfortunate things that happen. And in that situation, it became both a delivery bottleneck, but also a question of lukewarm demand. But it did start that way, and I'll show you some data to do that, to show that. So this 70% coverage, is not happening, and unfortunately, it will not happen differentially, and it will not happen in situations where there are fewer resources. And so, in this uneven vaccine access, and sort of this shows that at the country level, so what are some of the big countries where the population is covered, etc. So just country level coverage without accounting for the size of a country loses some nuance. So similarly, we have the same issue with treatment, and Paxlovid, which has 85% effectiveness. I can tell you, for someone who has worked on HIV trials, etc., it's pretty good effectiveness for an antiviral. But it has to work with communication. It has to work with testing and early access to the treatment, and we are failing the world on that as well. So a few of us worked on this, colleagues with, actually economists from Bocconi and a few colleagues from political science here. We collaborated and we showed, even before Omicron, et cetera, that as countries approach, and this was our initial work came out in November 2020, before the start of the immunization program, and then it was sort of came out in peer-reviewed literature a little bit later, that it's in the self-interest of even countries like the US to donate, to make substantial donations to Gavi Advanced Market Commitment, AMC countries, in terms of their own risk. And this was before accounting for risk of major variants, et cetera. And then with colleagues over the summer of 2021, like Greg Gonzalez, who will be there in one of the afternoon sessions, and a lot of other colleagues, we co-hosted sort of a gut check under the Chatham House rule, which with former industry partners, activists, etc., to create a blueprint of what should we advocate around. So it was a kind of a three-pronged strategy that was then became the basis of advocacy in Western countries for low-income country vaccine access. It did generate a lot of noise. The three prongs were direct donations, increasing capacity domestically for global export of a variety of vaccines, serious investments in mRNA vaccines as a technology that should be available to even low resource settings. And the last thing was end-to-end technology transfer. And sort of, I've been working on vaccines, different aspects of vaccines for over 20 years, and would be happy to elaborate on sort of, it was almost arrogant to say that you cannot do it. You may not be able to do it to every country in South Asia or Sub-Saharan Africa, but you could do it to enough countries in South Asia and Sub-Saharan Africa to make a serious dent. So with a colleague who's out of Yale now, we proposed a pandemic trust fund for the next one. And the idea was that this inequity cannot stand, and it's not that we need money for the next pandemic for diagnostics and vaccines and treatment, but we need it early. So we need an entity to be able to have the power to say to manufacturers that this money is there and this money is predictable if you so choose to innovate and develop vaccines in large quantities. And we propose several models: direct support, a NATO-like model where countries come with their expertise and some resources and a few things in between. And so this came out in Foreign Affairs, and the idea was to start a discussion. But I think this is the discussion we cannot avoid and we must not avoid. There are other ideas around the different trust funds and so on and so forth. I will briefly mention some of the things which will be covered in later sessions. I had the privilege very early on of being engaged before any vaccine was licensed in the summer of 2022. A group at the National Academies of Science, Engineering, and Medicine were tasked to come up with an overall framework within country framework, which actually I know directly informed between country framework of who should get the vaccine first, because the size of the population of which the size of a subgroup or a risk group in a population dictates how much vaccine a country should get. And so there are a few things that we decided on earlier on. There were a lot of choices. There was a lot of, I remember the first meeting, people were arguing for children getting it first, and there was not a settled strategy. What seems intuitive now, which is go for the older people first and healthcare workers, wasn't a settled strategy. And I was in the room, both on the WHO side and the domestic side. It wasn't a settled strategy. In fact, there was a paper in Science with 12 of the most prominent ethicists, led by one of the people that I really admire in this kind of thinking, talking about the years of sort of, crudely defining in simple language, without going to jargon, essentially the years of life lost by a productive group and maximizing, what investment you've had by someone who, societal and individual investment and their opportunity to live out their lives. So based on that calculation, the young adults were prioritized as the very first group to get the vaccine. So it wasn't settled there, but here's what the thinking and a lot of people, both from management side and economic side and other sides, know that this is, one thing we have learned is that groups make better decisions than individual on average. And I think this was, I can tell you that we got to this because there wasn't like one or two people innovating around. And so we said that there were two goals that, such a program, both within country, but as an extension between countries, should focus on. There could be two potential approaches: reduce morbidity and mortality, and then reduce negative societal impact. And we said both of these are important. And how you reduce, target these things are slightly different. One is through direct reduction of mortality, you have an impact on societal impact, but direct protection to individuals and indirect protection against severe outcomes is targeted towards the top one. But towards the bottom, you need more protection against infection. And we made a decision earlier on that we will privilege mortality and severe disease over societal impact. And here's the reason why. First of all, and when we developed a risk-based criteria for prioritizing these groups, risk of acquiring infections, just risk of severe morbidity and mortality, risk of negative societal impact, and risk of transmitting infection. And what we did was, we then privileged, based on these criteria, the risk of morbidity and mortality, because first of all, mortality is irreversible. If you start hearing about people coming back to life, that's a bigger news story than any pandemic. And so that's one thing. It sounds intuitive, but that wasn't being discussed as a given. The other thing is we did not know that these vaccines would protect infection and how effective they will be around infection. And there were those uncertainties around there, and it turns out that that decision to not sort of assume that was somewhat prescient. And and then we said, then you go to protection, broader societal protection, but privilege direct, for the first few doses. It doesn't mean that the societal impact is not important. It is who gets it first. And by that extension, which country, how you allocate between countries. So similarly, I had the privilege and somewhat unique privilege of being part of the other group at WHO. And so the first thing that designed this globally, and at WHO for the first time, again, before vaccines were available, we started with a values framework. WHO in the area of vaccines did not do that before this exercise. We explicated the ethical principles and how they would translate into policy broadly. And then we created a roadmap based on that. All of that before knowing what would be the vaccine characteristics. And then that was so that we didn't have a choice because the countries had to get ready. And these were the principles that we applied. I'm not going to go into the details of those, but I will say that we have updated that roadmap and we have said that you should do the same thing. And this is the more up-to-date version of the roadmap, which is irrespective of the vaccine. And it says that you start with the highest priority groups are older adults and health workers and immunocompromised workers. You go through those primary series as well as boosters. And that has implication across countries as well, because it is okay. I don't believe it's a zero-sum game, loosely speaking, that you don't have to say that you vaccinate everyone else in every country before you get to boosters in the US, and there are sort of ethical, formal ethical scholarship around it. because countries have the primary responsibility towards their own population. That means Zimbabwe, India, but also the US as well. But there are limits to it. When you reach sort of approach levels that can reduce the catastrophic nature of that, it's your primary responsibility becomes more global. But you go in the same sequence. One thing I would do different, and we push for it in the next round, is to make it simple, fewer tiers. And that's the lesson we learned. I will skip this, and I will I know Mushfiq will discuss it later as well. At the beginning of right before the immunization efforts commenced around the world, I had the privilege of being invited by Mushfiq to work on a large study with a lot of collaborators. Some of you may be in the room, and it was very helpful to have this kind of a collaboration to look at 10 low-income countries and Russia, and 10 LMICs and Russia and the US as benchmarks to see, before you started the program, what was the baseline available for acceptance. And in each of these countries, irrespective of the subgroup, the acceptance at baseline was higher in LMICs compared to Russia and the US. And this is more, focused effort, focused data. And, but here's the thing, as there was pushback in 21 to make this equity, make vaccine distribution more equitable, the point came, so a talking point, on the one hand, it's people like myself and Mushfiq, posting on Twitter, doing serious stuff in between, posting photos of our parrots. I don't, who you are. And on the other hand, there's professional PR people that are available to vaccine companies. And one major talking point is that the acceptance is lukewarm. Of course it will be lukewarm. If you have a year of supply shortages, you haven't built up the system. But at baseline, when you measured, I wouldn't say apples to apples, but this is not an apples to Brussels sprouts comparison, using similar tools, similar methods. At baseline, it was higher in these low-income countries, low and middle-income countries. And when we did a more focused national survey in May 2020, and Amin, who's the first author, Amin Malik, one of my postdocs, who's going on to do a grown-up job very soon, was instrumental in leading that work. And what we showed was that it was only 67% in the US that would accept the vaccine readily, and then there would be a gap. Some would accept it and others would not. Guess what is our current coverage of the 2-dose vaccine? Can anyone guess the New York Times data? 66%. We were off by 1%, sorry. And the reason I'm saying is that this wasn't rocket science. Kaiser Family Foundation, anyone with a half decent survey instrument said that there was some softness in vaccine demand in the US. But we never use that as an excuse to decide on the number of doses that were ordered for the US. Never. Wasn't even part of the conversation. So yes, going forward, we need to invest both on supply, end-to-end technology transfer, but also specifically on demand and vaccine delivery. Thank you. But not use this as an excuse. So these were backup slides. Yeah.
Thank you, Dr. Omer. That was a stirring call that we shouldn't use that as an excuse for vaccine equity. I will now call on Dr. Kremer, but I do want to remind our audience that you are required to wear masks in the auditorium. And if you don't have masks, we do have a supply, so we can give you a mask. Thank you, Dr. Kremer.
Just to justify our hypocrisy, the people who are teaching or on stage, if they are 12 feet away, can take off our masks. So just to make sure that we are not outlaws, at least not in this sense. We're okay.
Okay. Inequity at work. Great. Well, so I'd like to talk about lessons from COVID-19 for pandemic preparedness and response. And I should say that this draws on work with many different co-authors who collaborated through an informal group called the Accelerating Health Technologies Group. And I'll cite a few of the papers, but let me, on this slide, put your references to some of them. And I guess I should also say that although I'll be speaking primarily about vaccines, given the theme of the conference, there are issues for non-pharmaceutical interventions, for treatments, for diagnostics are also critical. And I do think a lot depends on the specifics, so I wouldn't wholesale carry everything over that I'll say about vaccines to these other issues, but there are some analogous issues. Even for vaccines, things will change with the technology. So a lot of this was based on work done. Oh, this is the wrong slide. Early in the pandemic. Okay, so things may change for the next pandemic. So we start with the observation. I don't know if there's a way to get the, I'll just do this. Hopefully you'll be able to hear me. So in a pandemic, the social value of vaccine capacity is much greater than the private value to a pharmaceutical firm. So let me just start with that idea. And let me emphasize why there are two greater than signs there, because it's a lot greater. Just to illustrate this, these are obviously all of these numbers are a bit, they're a bit imprecise, but I think they illustrate the issue of the order of magnitude. So the IMF estimated a $12 trillion loss in GDP, short-run GDP losses alone over 2 years from the pandemic. That works out to $500 billion every month. Now, serious efforts to try to think about the overall costs are much, much greater, almost an order of magnitude greater for the United States, where Cutler and Summers did a paper that tried to look at, say, for example, the educational losses, the health losses as well. And we don't know whether the ratio would be the same worldwide. I haven't seen, at least I'm not familiar with studies on that, but I think there are reasons to think that this 500 billion a month is a severe underestimate of the larger losses. Now, using those types of numbers, we estimate that the marginal value of an additional unit of vaccine production capacity, that is the ability to make one course of vaccine per year, in early 2021 would be about $1,400 per course of capacity. Now, would a firm be able to make that much from selling? Well, of course not. In a crisis like this, there are ethical limits, there are social limits, and ultimately there would be political input limits on the ability on pricing. And if you think about the actual prices that firms got, it was maybe $6 per course for some of the less expensive vaccines, AstraZeneca, up to say $40 for some of the mRNA vaccines. That has several implications. First, and this is really just principles of economics, the first economics course that one takes. When there's a big gap between the value of something and the price at which it could be sold, there are shortages. And all sorts of behavior appears during shortages. A lot of very unpleasant behavior, as we've just heard, appears. Now, I'm not suggesting that we should have let the price go to $1,400 per dose if that would have been the market price. That would have had its own problems. But I think we can apply certain lessons from economics about what happens in those situations to think about what other actions are needed. So one implication is that if private incentives to generate additional capacity don't match social incentives, then there's at least a prima facie case for the government to get involved in trying to boost production and trying to subsidize production. And with this magnitude of the difference between the social value and the private value, it's not just that you want public subsidies for production, so co-authors and I calculated, and obviously a lot of assumptions go into this, that you want many different shots on goal. You want, we heard about different types of technology for producing vaccine. And early on, we didn't know which one would work. And in some ways, we got very lucky. We obviously have many diseases for which we still don't have any vaccine after decades and decades of trying. In the case of COVID, there were multiple approaches that had at least some success. But in our analysis, we relied on historical data, assuming quite low probabilities of success for any one vaccine. And we still estimated that it was worth, from a social point of view, investing in many, many different vaccines. Moreover, not just taking many shots in goal, but acting in parallel. So the normal course of vaccine development, first you manufacture a little bit, do some testing, but you don't install the large-scale capacity, which can cost hundreds of millions of dollars until you know whether the vaccine's working. Well, hundreds of millions of dollars is a lot of money, but it's not a lot of money when when society is losing $500 billion every month in short-run GNP costs alone, and much more in comprehensive costs. So it actually makes sense to say, these are risks worth taking. Maybe the vaccine won't prove to be efficacious. It's still worth it to build a large-scale factory. And so I've done earlier work that was mentioned on advanced market commitments, and the group thought about what were the appropriate types of contracting and incentives for the case of COVID, and came up, and there are some differences, and we came up with a somewhat different approach. But the general point that it's worth, because governments are never going, governments and society more broadly, are never going to let the price of vaccines in an emergency equal their social value. It then makes sense. We can't count on firms to make adequate investment on their own. And it makes sense for governments either to undertake that investment or to subsidize private firms to do so. Now, there was a trade-off, as perhaps you can gather from the previous presentation. We recommended this approach to everyone who would listen, and indeed, the U.S. and the UK made very large early on investments in backing multiple production facilities, and they had the resources to do so. Now, one of the issues, I think, would remind everyone of another principle from introductory economics, which is that elasticities of supply can be quite, in the short run, can be quite low. It can be very difficult to put a lot of supply in quickly in the short run. If you have much more time, then elasticities of supply are much larger. So if we think about a normal supply and demand type diagram, if you have, these are just meant to be illustrative. Don't take the actual numbers too seriously. But if you think about that, so yellow might be a demand curve, the social value of additional doses of capacity. The earlier you get the vaccine, the more valuable it is. That's why capacity is so valuable, because it allows you to speed up vaccination. Think of the blue curve here as the short run elasticity of supply. If we spend more, we can get more production, but it's a pretty steep, you have to start spending a lot more. And it actually turned out that much more vaccine was produced than people forecast early on. So there was some elasticity. It wasn't zero elasticity, but it's inelastic. Well, in a normal market, if you start demanding more, that's going to drive up the price. You shift out demand for capacity, and that would drive up the price, and that might deprive some other countries of access. Now, if in a market with price controls, it may not be that price does the rationing, but still, if there's inelastic global supply, somebody might lose out. So there's a trade-off of this. And you can debate this about what was the net effect of, say, Operation Warp Speed on. I tend to be a little bit more optimistic about it than some others, but you can argue that there were some negative effects in the short run. But let me just point out that if we think about the future, the long run situation is very, very different. So if we're thinking about pandemic preparedness, I've drawn a flat supply curve in red there, where you can build with enough time. There's nothing to stop a vaccine production capacity from being expanded at roughly the same cost. And maybe that's a little bit upward sloping, but not substantially upward sloping. So this trade-off between is it good or is it bad for the rest of the world if one country builds production capacity? Well, there is a trade-off in the middle of an epidemic. If we think about pandemic preparedness, there's much less of a trade-off. And in fact, it arguably might even go the other way, because COVID is on our mind right now, but obviously there are many other epidemics that affect one region of the world. And one thing COVID taught us is, this can affect any region of the world. If you think about Ebola, you might say, oh, it's going to be the poorer parts of the world that will be affected. Well, we saw in the United States, for example, that rich parts of the world can be very affected as well. So if you don't know which regions will be affected, if you build out, it might be in a country's self-interest to build out additional capacity, but if they don't happen to be hit by the next epidemic, they might be able to make some of that supply available. So there might actually be positive, what economists would call externalities from this. Okay. So an implication of this is that by investing now, we can avoid some of these very difficult situations that you get if you start investing in the middle of a pandemic. Okay. So let me, this is a discussion about equity is the theme today. And so far, I've just made an efficiency case that it makes sense to make these investments. Let me just point out one of the reasons why this also promotes equity. So think about, the first reason and the simplest reason is that if you increase broadly defined production capacity, and let me be clear, by production capacity, I'm not just talking about the number of factories. You need a bunch of inputs, you need a bunch of human capital. Maybe we don't know what the next pandemic is going to be, but we probably want some bioreactors around and some adjuvants and so on, and human capital of people to run this. So suppose that in a business as usual scenario, whatever that is, it's going to take 1 year to vaccinate the world. Consider the impact of doubling capacity. Well, if you're just a month into that queue and capacities double, then we're going to be able to vaccinate the world in half the time. You go from 1 month into the queue to 2 weeks into the queue. You save 2 weeks. That's great, but it's a limited benefit. It might make the difference. I shouldn't say it's a limited benefit. It might make the difference between life and death if you're infected and weak, early on. But if you're at the end of the queue, doubling the speed with which the world can be vaccinated moves you from a year in to 6 months in, and that could very easily make the difference of whether the vaccine arrives in time for you or not. So that's the sort of direct mechanical engineering of benefit to equity from having more capacity and shortening the queue. But let me discuss a further benefit, which might be a little bit less obvious. So I referred to the shortages before. If there's a shortage, when the price is much, much more than the value of the vaccine, governments face very strong incentives to prioritize their own population. And the case of the United States under the previous administration was mentioned, and obviously that's a case, that's an administration which had this logo of America first. So it's perhaps not a surprise they acted this way. But I think there's a much broader point here. I don't think it's just we're living in a time with a lot of nationalism, but I wouldn't put this just down to the very strong forms of nationalism that are common in the world today. Elected politicians have very strong incentives and arguably responsibilities to serve their populations. And so in these situations, there'll be strong incentives to put on export restrictions, as the United States did, as India did. And we heard about the countries buying more than enough vaccine for their populations, even assuming that everybody was going to get vaccinated. And we heard that probably it didn't make sense to think that everyone would be vaccinated. But if you don't know whether you'll be able to get extra supply, you're thinking, well, what if? What if we get more people want to get vaccinated? What if we need extra boosters? What if some supply we think we have, we lose because it turns out that there's a side effect of a particular vaccine? So there's very strong incentives to do that hoarding as well. Now, I think we should be making moral appeals, and I think that's part of the solution, but it's unlikely to be a complete solution. And here I think it's useful to bring in some concepts from game theory. We heard about a game among countries. So let me bring in the concept of a Nash equilibrium. Every country trying to do what maximizes the benefit to it, given what every other country is doing. And in a shortage situation, you get these incentives, to hold on to vaccines. Well, if you can avoid or mitigate that shortage, that weakens the incentives for this type of behavior. And so if you think about how can we change the game that countries are facing in a pandemic, well, we change the game by investing now in extra capacity. And then there are going to be weaker incentives to have this type of vaccine nationalism that we saw in the COVID pandemic. How, that sounds like nice theory, but why should we believe that? Well, I think we actually have an example. If you think about the case of personal protective equipment, very early in the pandemic, when there were shortages of this, you saw the type of shortage behavior that you see in other markets with shortages. People buying this up, hoarding it, trying to grab production before it's exported, export bans. Well, once there was enough supply of personal protective equipment, then this type of behavior stopped. So I think that we can try to put this in place going forward. But let me note, we heard about proposals for pandemic trust funds. Let me note some principles I think might be worth thinking about to complement the types of principles that we heard about already, which I think are, play a very important role in thinking about how to design vaccine allocation mechanisms. So first, let me note that there are huge potential gains to international cooperation. One reason that was pointed out was that diseases spread. But let me point out another one. Again, something that we have the advantage, the strange advantage of by acting before we see the pandemic, which is we're behind a Rawlsian veil of ignorance, if you will. We don't know who's going to be hit by the next pandemic. So we could all decide, just like we don't know who's going to be hit by the next fire. Well, we could all build our own private fire department, and that might be necessary if we all got hit by fire at the same time. But in many cases, we don't all have fires at the same time. So we club together, and the town, the city, gets a fire department that serves all of us. Well, there might be gains. I'm not saying these would be easy to realize at all, and maybe even this is a pipe dream, but there at least potentially should be gains from working at an international level to put this capacity in place and to agree on rules for how it's going to be used. But if you want countries to participate in a system like that, you have to at least think about what are the incentives for them to join. And you have to think about that ex ante. You know, if you're United States, you may well say, hey, whether it's a Republican or a Democratic administration, you might say, that's very well and good, but are we really going to get a hold of this in an emergency? We better build our own supply. And I don't think building their own supply is a problem for the rest of the world, but it might not be getting the advantages that we would like to see from an international system. But you not only have to think about the ex ante, and so that might mean, you know, that might mean some designing those features, even though there's some cost to that encourage countries to contribute. For example, among countries with the same income level, maybe countries that contribute more should be prioritized. There are trade-offs in doing so, but I think it's worth thinking about that for ex ante incentive compatibility. You also have to think about ex post incentive compatibility. Across a range of scenarios, are countries going to live up to these agreements? Are they going to, well, there you might also think about how to design systems so there are incentives for that. You know, one way to do that, I don't want to overemphasize this, but if you think about, if you're a large country and you've got some vaccine supply, well, there's going to be very strong incentives to hold on to that, and that might slow down distribution to the rest of the world. If you're Singapore and you decide we've got lots of vaccine production capacity, well, let's use it for our population first, well, that's not going to slow down vaccination for the rest of the world quite as much. But there might be other ways to create incentive compatibility. I don't want to focus entirely on the small country, large country aspect. Let me just say a bit about, I focused a lot on manufacturing capacity broadly defined, but I think we also need institutions for research to be developed in advance. And you know, if we can speed up the research process, then that and the testing process, you know, we actually had the mRNA vaccines very quickly, but we didn't know that we could use them because they hadn't gone through testing. Now, there are very complex ethical issues and there are very complex scientific issues. And there are people here who are on this panel who are far more expert than me on these issues. I don't want to try to go back and say what would have made sense for COVID-19. But clearly, you can imagine future diseases where it would be clearly unethical to do human challenge trials or might not be scientifically feasible. But there might be other cases, let's say, you know, something that affects some population knows there's virtually no risk for this. Well, maybe, you know, they get infected, but it won't cause serious damage. Well, maybe a human challenge trial would be okay then. Well, it's probably worth thinking through building both sort of the ethical, the infrastructure and the scientific infrastructure for how to do this so that we can use it if needed, if appropriate. Thinking about how to do adaptive trials so that perhaps the trial population gets adjusted in between arms. You know, new people entering trials might be moved from one arm to another as we get data on what's successful and what's not. Thinking about dose stretching policies. I think I'm out of time, so let me. I'm happy to talk about that afterwards. But things like first doses first, trying to test for that, trying to test for the. You know, happy to talk about this more. But what's the optimal dosing? You know, there's reason to think. This is a hypothesis, far from proven, that perhaps even quarter doses of some vaccines would have been highly effective. If we could have vaccinated 4 times as many people and perhaps had weaker you know, side effects, so people were less likely to feel sick a couple of days after vaccination, that might have been very valuable. Right now, there wasn't incentives to test that properly. Well, for the next pandemic, let's try to make sure that there are resources to test that early on, so if we need the extra vaccine, we can get it. I think, you know, we learned a lot during this pandemic. We accomplished, you know, it's glass half full, glass half empty. But I think we can do a lot better next time. And now is the time to invest to make sure that we can. Thanks very much.
Thank you, Dr. Kremer. I think it's worth reflecting on your point that capacity is not just builds efficiency, but equity. And the point of those at the back of the queue, it actually, really cuts down their time. Sometimes we can't see those people at the back of the queue. So I think it's worth reminding ourselves. We'll take questions now. So we'll first start with the group here that's in the auditorium, and then I will turn it over to Haley. We do have someone with the mic. We do have Vaishnavi with the mic. So raise your hand. She'll come to you and you can ask questions to Dr. Omer, Dr. Kremer, both.
Thank you both. So I wanted to, push you a little bit, maybe a little bit outside your comfort zone on on something you both mentioned, right? So we were talking about. I like the fact that both of you weren't just looking retrospectively at what happened with the COVID-19 pandemic. I think many people in the room, many people on Zoom, we're probably sick of the COVID-19 pandemic now, but we need to think ahead prospectively to what can we do better, right? And how can we avoid the mistakes we made, right? And so Michael ended the talk with pandemic preparedness and what institutions we might want to put in place. And Saad alluded to this foreign affairs piece on a pandemic trust fund, right? And I was hoping that we could get a bit more specific on this, right? So Michael talked in abstract terms and like principles we should follow, right? But what should that look like? What is that institution that we need that doesn't exist? Like, should that be inside the WHO? Should that be something different outside? What are the incentives involved?
So we started the discussion on this with the understanding that it was a starting point, and the few ideas we proposed. So first of all, we proposed that it should be an entity that should be heavily controlled by WHO, because WHO is a political entity. UNICEF isn't, CEPI isn't, Gavi isn't, and is grounded in international law. So, so for various reasons, WHO should have a heavier governance role without being the sole global entity responsible for governance of such a trust fund. And the example, a loose example, were Gavi, the Vaccine Alliance, and Global Fund for TB, Malaria, and HIV. But we drew some distinctions. We said the money should be there, obviously, in advance. The money should be set aside for pandemic level spending, but also what we, realistically but disappointingly call the inter-pandemic period. It's not a new thing. The term has been there. There always is an assumption that there's a next one coming, and so some investments there. The other thing we said that it should not be exclusively focused on vaccines. And we, as someone, look, I'm a vaccine. My own primary research is on various aspects of vaccines. I want vaccines to be the savior, but vaccines are not the sole savior in this pandemic or any other pandemic. And so therefore, investments, there's a reason why there was such confusion around masks and such irrational and inappropriate decisions, because we haven't done the research that you and Jason ended up doing, and others ended up doing in Bangladesh, etc. So do these kinds of things that are of global benefit. A single country has no mechanism to do that. Build capacity. What Michael talked about. Build capacity. Build human capacity, human resource capacity, and figure out, and we had a separate report that I didn't mention that was tasked by the US government to the national academies, which just came out like 2-3 months ago, on influenza capacity and preparedness. And so we discussed a lot of these issues, borrowed and stole from a lot of these ideas that put out, and so talked a lot about, how do you make sure, where do you, in a lot of detail, it should be whether it should be an academic entity that trains low and middle income country workforce And what does that workforce do in the inter-pandemic period? So a lot of these details, so the devil is in the details, as you are alluding. Then there are various models. So a money-only model, a NATO-like model where countries come with their skills and resources and commitment, but not necessarily direct resources. And then a few other sort of models in between. So, but I think there needs to be a lot of discussion. I don't think there is political appetite to move on this now in terms of the executive parts of the government. But there are enough lawmakers in various countries that you can maintain the momentum and make it part of broader legislative efforts. And because at the end of the day, Gavi happened, and the Global Trust happened, and efforts around malaria happened, and so on and so forth.
Sure. So I'm not a political scientist. I'm not a specialist on the institutions here. So I don't think I have a proposal to advance. But I do think, if I think about these issues of incentive compatibility, I was involved in a panel to advise the G20 on these issues, I believe. And if we think about what are the incentives, I think we heard that in the previous pandemic, or in the continued pandemic that we're still in the middle of right now, high-income countries did not participate to the extent that one would have hoped. I think that's partly why I emphasized the issues of incentive compatibility. What is going to actually bring them to the table? We could design a system that would be completely fair and completely just, but if it has no resources in it, it's not going to be very effective. So one I think a very likely outcome is that not that much, something will happen, but it'll be nowhere near the scale that we need, and that countries will wind up doing things on their own. And that we will go into the next pandemic not very well prepared, or not nearly as well prepared as we should be. One approach. So WHO has, I believe, you can inform me, voting on a country basis, and now there are other institutions which have voting based more on the financial contributions, like the World Bank or the IMF. There's a trade-off there. In general, there are reasons why we moved away from inside countries from voting based on how much taxes you're contributing or anything like that. But having some system that provides more control to countries that are putting in more financially might lead to more participation. So it's not even that I'm not a political scientist. I'm not a philosopher. I'm not going to try to take that on, but I'll just say that there are trade-offs.
Since you've said you're not a political scientist, let me ask an even more ridiculous question then, but just to push you more. And by the way, you don't necessarily have to answer it. If the answer is, don't ask me, that's fine, but maybe others in the room can contribute. So after the last huge crisis we had, which was World War II, right? Lots of institutions of international cooperation emerged, right? And they were global. Some of them, like the United Nations, has one country, one vote type institutions, but they also have the Security Council. And some of them, like IMF, World Bank, the Bretton Woods institutions, was based on contributions, right? And then after that, we had GATT, then WTO, right? So we had, I guess I mean, of course, I wasn't born then, but my guess is, like, we saw what non-cooperation can lead to and the immense harm it can do. And right now, with the pandemic and with climate change, we're getting another taste of that. And the world seems to be moving away from that, like what we're dealing with right now. You mentioned NATO, Russia invading Ukraine, etc. Right? So what is going wrong? Is it that we've just forgotten what non-cooperation can lead to? And are you optimistic or? pessimistic about this?
So, you mentioned Russia and Ukraine. So let me draw a little bit of an analogy between, I'll try and be an amateur political scientist based on what I remember from when I was an undergraduate taking, international relations 101 many years ago. If you think about the debate between the idealists and the realists, and from an idealist perspective, we might want something along the lines of what was outlined in terms of the Pandemic Trust Fund, with a very heavy role for the WHO. Now, idealism in general, as you point out, is not doing very well these days, and there's a realist perspective that, hey, we need to invest on our own, we need to build our own factories, we need to have our own production entirely domestic, because that otherwise we're not assured of anything. Well, let me just argue that the quote realist perspective in this case is not actually very realistic. And if you think about the case of China right now, China made a decision, the realist, tough decision, we're going to produce our own vaccines and we're going to rely on those, and we're not going to rely on anybody else. Now, US went with Operation Warp Speed with very heavy investment in these mRNA vaccines. The US got, lucky or smart or whatever, but there's some luck involved. It could have been the Chinese vaccines, as we heard, could have been the Chinese vaccines that worked, could have been the US vaccines, the mRNA vaccines that worked. There just happened to be technological specialization in different parts of the world and different types of vaccines. Well, China right now, we're seeing these terrible crises that they're facing because they decided to rely entirely on domestic production. And they didn't make the decision to say, hey, we're going to try to create, if everybody had created an international system, and you would have had to make sure it's incentive compatible. I don't think you can just sort of toss the realist perspective out the window. You need to design it so that countries will participate and countries will have incentives to follow the rules that they've signed up to. But the idea that we're going to go it alone actually isn't very realistic either. And if it's not realistic for the second largest economy in the world to do this, it's surely not realistic for the Australias or the Canadas or the similarly sized lower income countries to do this either. Australia had actually a similar experience. They went with a particular production technology and it didn't work out. And then they had a long period without access to vaccines.
Hi, thank you very much for your very interesting talk. I was especially interested in the discussion of demand for vaccines and how that affects costs and also incentives in terms of making a difference. So early on, one of the NIH reports similar to the one that you had at the beginning of your talk was about vaccine hesitancy. And so my team and I developed this tool to counter vaccine hesitancy. And I've been trying very hard to distribute that tool, and it turns out to be extraordinarily difficult. Connecticut state government, the CDC, there are roadblocks all over the place to actually being able to distribute really good, tools to counter vaccine hesitancy. Meanwhile, the people who are against vaccines have this extraordinary success in using social media. And I was just wondering if you had any way of quantifying the cost of vaccine hesitancy, and if it's possible to come up with an incentive structure to actually motivate countering that in an effective, concerted way, because right now we're doing a terrible job of that.
So that's a really good question. I'm assuming by you meant me. Okay, it's the uncanny resemblance we have. So just you're absolutely right. And I am actually a big fan of aspects of the Operation Warp Speed. I think it was an incomplete system. It should have had a global collaboration element to it. And as Michael alluded, if you look back and say, how the heck did the two major powers with complementary skills and complementary assets, the engine of scientific innovation, the US, and the biggest manufacturing infrastructure, China. India has the biggest vaccine manufacturing infrastructure, but China is not far behind in terms of vaccines, but has the biggest, like, sort of the ability to mobilize industrial, high-end industrial infrastructure resides. How the heck did we not collaborate in our own self-interest? So I'm not a sort of a dove or a hawk in terms of other stuff, not my area, but in this situation, sort of we didn't look at sort of our self-interest. Coming back to your specific situation, your question, in Operation Warp Speed, I remember September 2020, there was a series of off-the-record, not background calls, so they were acknowledged that those calls were happening. And many of us with the Operation Warp Speed, apolitical calls, to provide input. And the single most salient theme was that we were not spending on vaccine education. That was framed as different ways, vaccine acceptance and all of that stuff. Some of us are on the record as early as March 2020, well before our survey. There's a reason why we had a survey out in May, because we had this intuition from previous pandemics. In 2020, the first appropriations that happened, there was 250 million approximately to the HHS to counter COVID despondence, as if it was a magical, so people got the vapors by hearing the name of, by encountering the word COVID, as if it wasn't anything biological or epidemiological, as it wasn't killing people, and by sort of investing in increasing acceptance of these things, or just meat and potatoes vaccine information. So it didn't happen in the first appropriations. It happened a little bit in the subsequent appropriations. So there's a huge push to communities. So the Biden administration has put out have put a lot of money to community-based organizations. But the gap there is that there should be a technical support unit at the CDC level to get that out. So to provide that support to communities and local health departments and sort of the other stuff. Even now, so these kinds of interventions are an afterthought when it comes to applied interventions. I'll give you an example that with treatment, the Paxlovid example, highly effective. Physicians don't know about it. Patients don't know when they're eligible. They don't know who to call and when to call. And we have sort of known that this is coming. That's our part of our exit strategy. And so what needs to be done, there are 4 or 5 things that need to be done. First, we need to focus on a national continued medical education program for healthcare providers, because in study after, so I have never done a study on vaccine acceptance in my last 20 years, where the most, not one of the most, the most trusted source of vaccine information is not a healthcare provider, irrespective of political inclination. It changes, but within group, that's the most salient one. There's also a skills gap in healthcare providers in terms of evidence-based communications around vaccines. Number one, that needs to happen between now and fall, where the next big wave is likely to come. There may be sort of bumps in the middle. Second, in terms of vaccines, we need to make sure that vaccine counseling that has really, vaccination itself has high returns on investment. And there's a lot of social value to sort of, even for individual protection, there's high social value. If people are not in ICU, everyone benefits. And so we need to make it reimbursable. It should be a reimbursable code. That's number 2. Number 3 is the fact that this technical support, along with current investments, because we should demand some we should demand some evidence-based assessment and deployment of evidence-based interventions, and the same level of rigor in vaccine demand-side interventions as we demand in vaccine development. So that's number 3. So do that. Number 4, we need to decrease, and this is true here and globally as well, the political temperature of vaccine conversations. We have been doing sort of experiments throughout, and politics matters. Who's saying what matters to the other side, not just your own side. And so we look, at the end of the day, on all democratic societies, the president or the prime minister has the ultimate responsibility. So the executive branch should be held responsible for public health emergencies, and then in the long run, the legislative branch. So it is understandable that the White House would want to be involved, but not every briefing has to be from the White House. Not every briefing, even if it's a physician appointed by the White House, at the end of the day, they're a political appointee. We need to have briefings by people in public health service uniforms. You may have seen that there's a fourth or fifth service. It's a uniform service, which is based on public health people, that CDC folks who are career public health service people wear that. So people in the public health service uniform delivering meat and potato public health information from Atlanta. Career people doing that. And it's not a novel, innovative concept. We did exactly that during Ebola. We did exactly that during H1N1. We did exactly that during anthrax, which could have been highly political. And so we need to do that, start doing that right now. So it's not just resources, but an approach that in political responses and political communications, you win on the margin. A 2 percentage point advantage is huge, but a 2 percentage point advantage is 52% vaccine coverage. We need 80% vaccine coverage. We need 90% vaccine coverage. And so these are the things I think we need to focus on going forward. Sorry, it was a longer answer, but these things are nuanced.
Thank you. Do we have a final question before we go to coffee break, Dr. Kangwai? And we'll be having a lot more about the demand side in the next couple of sessions as well.
All right. Good afternoon. Thank you so much for the presentations. And my point is, in West Africa, for example, we had the Ebola outbreak in 2014, and now the COVID outbreak, the pandemic. And we saw with the Ebola outbreak, the response was different compared to the COVID, because COVID was a bigger scale, not so. And we saw with the introduction of the vaccines, while other countries were giving first, second, and even third dose, other low-income countries were without vaccines. Even with the recommendations, as we are saying, Professor, WHO, UNICEF, even recommendations for some of these key partners for the distribution of vaccine to countries that needed the vaccines, the big power countries, we are not responding. And we also saw some political, wherein countries were like referring to some vaccines as being the best, as the other not being the best. And even when traveling from one country, they will recommend a particular type of vaccine. As researchers, what recommendations have you put in place? Or what recommendations have you given to like WHO, UNICEF, or to other world powers? Because we know there will always be outbreaks. Outbreaks are bound to occur on different magnitude. What we have learned from the COVID-19, what recommendations have you given or have been put in place so that similar won't happen again, especially when it comes to the vaccine equity, the distribution of the vaccine, and the production of the vaccine, saying this vaccine is of a better quality compared to the other. Thank you.
My recommendation would be talk to Michael. It's a longer answer, but yeah. So there will be a lot of after action review. There are certain things that both of us, I guess, described that are already sort of getting some intention, etc. But I think things will settle down. And my sort of the bottom line would be, unless it's part of a political arrangement backed by specific resources that also works through, appeals to moral authority, but not exclusively so, that has incentives that align with countries' own incentives, etc. And it's a medium to long-term project to make sure that key players in countries that have their own self-interest in mind find it attractive to invest in these things. I think that's the key, and would be happy to have a sort of a longer answer over coffee.
I think it's a good point, especially with, I think, Dr. Kremer, you talked about multiple firms needing to actually produce the vaccine, but what happens when the brand name doesn't travel across countries? So I think that's something to keep in mind when we have that sort of allocation. But thank you very much. This was very insightful. Thank you to all those who asked questions. You'll get a chance to ask more questions. We'll move into a coffee break now till about 20 minutes, 25 minutes. Those of you who are online, we'll be back at 4 p.m. And please keep the questions going. For the audience that I can't see, that's